welcome and thank you so much for joining us here at Top Med Talk, our road show. We are here at 8020 Kalins in Louisville, Kentucky. We are streaming for the first time, so if you hear some feedback, it's because Monty still has his computer on.
Let's do that again.
Those that are listening at home, we love you. So if you hear some feedback, because Monty still has his computer on. Oh. Those that are listening at home. Oh, there we go. Why is it? Oh. I think that was it. All right.
Hey, Mom.
Hey, actually, hi, Mom. Everybody else. This is why we're doing this tonight for the first time. So let's get the slides back up and we will have a go. All right, so Top Med Talk Roadshow here in Louisville, Kentucky at 8020 Kalins. We thank you guys so much for joining us, and we thank you at Edwards Life Sciences, Brandon and Hannah.
How much fun is that?
No matter how many times you practice. Okay, one more time. From the beginning. All right, guys. So, thank you and welcome to the Top Med Talk Roadshow in conversation with here at 8020 Kalins in Louisville, Kentucky. Thank you guys for everyone here in the audience, but thank you for listening at home. As this is a live show, anything goes, right? So we're here experimenting for the first time. So thank you to the audience for kind of being our guinea pigs and everyone watching at home. Now, we could have someone watching in Australia, New York City, wherever you are. Thank you. And thank you to Edwards Life Sciences for sponsoring us this evening as well. So, like I said, it's Top Med Talk Roadshow, and we are in conversation with Professor Monty Mythen. So I want to introduce Monty, who is a friend of ours in Louisville. All right. Yeah, fist bump. We're getting it. Monty actually is a friend of ours here in Louisville. He's been here to talk to us several times about hemodynamic management, fluid management, and enhanced recovery. That's kind of his specialty. He's the professor and chair of anesthesia and critical care at the University College of London in the UK, not University of Kentucky, like the actual United Kingdom. And he has come here to talk to us tonight about hemodynamic monitoring and some of the things that we're involved with in enhanced recovery and fluid therapy, hemodynamic management of our patients. So I'm going to go ahead and hand it over to Monty. He's going to tell you a little bit more about himself. We'll get started. We'll take some Q&A in just a little bit. We'll go through Slido, the technology that we use as a Q&A platform, and we'll go ahead and get going. So Monty, take it away.
So folks, thanks very much indeed. Great to be back here in Kentucky. As I said, home of lots of famous things that I've heard of now, the Louisville Slugger, Muhammad Ali, Desiree Chapel's on the list now, but there we go. So I'm going to give you a very rapid update about where we are with some elements of perioperative hemodynamic monitoring and management. There's a lot that's happened in the last year. We're much better informed. I'm going to go through it pretty quickly, so I think we kind of know all of this stuff and get into most of it in discussion. So I've got some potential conflicts of interest that are disclosed there. The most important one for tonight is that this evening is very generously supported by Edwards Life Sciences in part, and I do consult for them. The other conflicts I don't think are going to come into play with what I've got to tell you about. So, first question, where are we with regards to enhanced recovery? Well, it is, what is it now, 22 years since Professor Henrik Kellett put out one of his first review articles about enhanced recovery under the title of Multimodal Approach to Control Postoperative Pathophysiology and Rehabilitation. Shortly after that, with a surgeon in Boston, Doug Wilmore, he wrote an article about fast-track surgery, which we all came to know as enhanced recovery. Now, 20 years is a typical cycle for broad adoption. And I think most of us think what we see in the world now is that enhanced recovery is going to become completely normal practice for all forms of major surgery. And I look forward to discussing that with you. Next question is about hemodynamic management in enhanced recovery. A lot of debate about this. Do we need it in fully implemented enhanced recovery programs? Well, I'll go into this a little bit detail later on, I hope. This is from the American Society of Enhanced Recovery and the Perioperative Quality Initiative, and these infographics describe how they think fluid management should be done for patients in enhanced recovery. They include, on the left-hand side, as you look at it, a sort of matrix for evaluating which patients might need more advanced monitoring, and in the center are sort of algorithms about levels of management, and I'll come back to that in a second. Which fluid to give? Well, the colloid versus crystalloid debate, we still don't know the answer to that question. So that's hanging, as we don't know what we should do about that. With regards to the choice of crystalloid, then the choice between normal saline, for example, and a balanced and buffered crystalloid solution, we're now as certain as we can be about that one. So the guidelines tend to say default to using Hartmann solution, lactated ringers, plasmolite, or something like that, because the fear that normal saline might be hurting the kidneys has borne out in some of the largest fluid trials we've ever seen. So published last year, although not in perioperative practice, in the context of critically ill and non-critically ill patients, about 17,000 patients were randomized in a novel design of a trial, and at the end of that trial, conducted in Vanderbilt in Nashville, it came out that normal saline was associated with statistically significantly more renal failure. So I think the guidelines that currently say the house wine, unless it's contraindicated, should be normal saline or Hartmann's stands at the moment. What about how much fluid to give? Well, we've checked off one of those boxes as well. In the early adoption of enhanced recovery, this idea of fluid restriction being good for patients crept in to the language. Whereas actually what was said was not fluid restrict, it was don't fluid overload. Give patients the right amount of fluid. Now the fluid restrictors like fluid restricting because they said, well look, my patients look great in recovery, they breathe well, they go home early, what's your problem? Well, some of the observational data says, well, when they go home, some of them go home and develop acute kidney injury that turns into chronic kidney injury. So that one's been checked off now in the largest prospective randomized controlled trial, the RELIEF trial, where led out of Australia, although it's an international trial, they randomized patients to receive either a so-called liberal regimen for patients undergoing major surgery, major intra-abdominal surgery, or a restricted regimen. Now, the so-called restricted regimen was about zero balance. So at the end of the case, they were up about half a kilo, about half a litre of fluid. The moderately liberal were up about 2 litres of fluid. And at the end of the day, although their theory was that the drier patients would have a better outcome, that did not happen. There was no benefit from being dry at all. Actually, there was statistically significant harm. There was more acute kidney injury in the patients who were run with zero balance. So the result there is basically fluid restriction is bad. There's no evidence to support it, there never has been. Don't do it. If you're going to do anything, just keep them a little bit moist, and I'll come back to that, a little bit wet. What about goal-directed therapy? What about goal-directed therapy? So I'm keeping the noise levels down so the people at home I'm not shouting at. I apologise to the people in the back of the room. From the point of view of goal-directed therapy, we've had one of the largest prospective randomised controlled trials, a recurring theme here in the last year, the so-called FEDORA trial, published in the British Journal of Anaesthesia. This is a prospective randomised controlled trial, multi-centre, out of Spain, of some 420 patients in 6 centres. And it reinforced the message from all the meta-analyses beforehand that using a goal-directed approach produces statistically significantly better outcomes. Less acute kidney injury, less lung injury, fewer surgical site infections, fewer deep surgical site infections, all of those things we've been told before. Now, a little twist in it is it wasn't just goal-directed fluid therapy, it was goal-directed hemodynamic therapy. So not just the idea of giving fluid boluses to maximize stroke volume, which I'm sure is what we do every day of the week. It combined with it an algorithm that says we must also think about mean arterial pressure and cardiac index. So once you'd corrected the stroke volume, you turned around and said, okay, I've maximized my stroke volume. What's the map? If the MAP's less than 65, do they need more cardiac index or do they need more squeeze? And that's the algorithm they applied to produce the better outcome. So now the question is really more about goal-directed hemodynamic management in general, as opposed to just goal-directed fluid management. And we're going to have more trials coming through to try and answer that question. When we compare those sort of trials, like the RELIEF trial, which is restrictive versus liberal, and the FEDORA trial, which is goal-directed, then actually, if you put those on a graph together, this is a little bit naughty, but it's been blessed by saying it's an important question. In the blue bars, as you look at it, is that large 3,000 patient trial where they did restrictive compared to moderately liberal. And the acute kidney injury rate was reduced by being moderately liberal. In the FEDORA trial, which was traditional care versus full goal-directed, managing both pressure and cardiac index, we see the lowest rates of acute kidney injury, under 1.5% post-operatively. So the ongoing questions are really, does that going to play out in large numbers? But that's where I'd want to be at the moment. And luckily, that completely aligns with the protocols recommended by the American Society of Enhanced Recovery, although written 2 years ago now, 2016. This infographic that you'll find within the paper says, is there a clinical problem? What do we think is causing it? Use my monitors, use my brain. And then once I've done that in higher risk patients, I'm going to address both preload, afterload, and contractility. What about blood pressure? We're all told now we have to worry about blood pressure. I think we've always worried about blood pressure, but perhaps some of us have let the blood pressure drift down to a lower level, particularly after induction of anesthesia. I think many of us over the years have become a bit more confident to say, I've put the patient off to sleep, sure, the blood pressure is going to sag, but the patient hasn't been cut yet, the afterload's down, the flow must be high. I'm not going to panic at this stage, I'm going to wait till knife goes to skin. Now we've seen these large observational studies where a MAP of 65 or below is strongly associated, even if it's transient, even if it's only as long as 1 minute, with a greater incidence of heart injury and kidney injury post-operatively. So there's a lot of pressure under now to say you should think about keeping the MAP above 65. Now we've had one prospective randomized controlled trial that has tried to address that, the IMPRESS trial. They randomized high-risk patients to receive a peripheral norepinephrine infusion, which I know is standard practice for some of you now, to keep their mean arterial pressure within 10%, their systolic pressure, within 10% of their baseline measurement. And when they did that over the course of surgery, the outcomes were significantly better. Now, it's a relatively small trial out of Paris, out of France. It's only about 300 patients, but it's a strong signal to say possibly keeping the pressure up is going to produce better outcomes. That having been said, published literally this week, the latest perioperative quality initiative international guidelines to be published on blood pressure have come out to say we think the current state of the art is we should not let the MAP go below 65. Until we know it's not going to hurt our patients from large trials, we shouldn't let it go below 65 because a lot of that signal of harm comes from the gap between induction of anesthesia and knife to skin. And if it happens between induction of anesthesia and knife to skin, there's only two people to blame, There's the patient, and we can't really criticize them under these circumstances, and there's us, because we made it go down and we didn't get it back up. So the big question now is, if we are going to keep the blood pressure up, how should we keep the blood pressure up? Is it that preload, afterload contractility? Is it giving little hits of vasopressor? Or is it like the trial? Is it having a lower threshold for starting a peripheral dilute norepinephrine infusion? We don't know the answer to that yet, but we're all looking into that. Coming close to the end of my short talk here, it turns out that this guidelines from the Perioperative Quality Initiative, the American Society of Enhanced Recovery, stand true today. So in 2 years on, there's no reason to change them, with one exception. When we look at this risk-adapted matrix on the left-hand side of the slide here, there's a reason to change one of the boxes in it. Now, I'm sure you're aware of this. This is the sort of idea that if you're trying to decide what level of monitoring to have to your patients, mentally what we do is we turn around and say, what's the risk of surgery, up one axis? What's the risk of the patient? So a very high-risk patient having very major surgery, we're going to use fully invasive monitoring, we're going to use goal-directed therapy of some form, and we're probably going to be sending them to post-operative critical care environment. If they're intermediate patients, we're going to be using less invasive monitoring. In this original matrix, as published in the Canadian Journal, it said in the bottom left-hand corner that goal-directed fluid therapy is not indicated, and the patients will probably be best served by zero balance approach, by aiming for sort of close to a little bit dry maybe. But with the relief trial, that's now been rewritten. This is in press, as I understand, in the journal Anesthesiology. The only thing that's changed about it is in each of the quadrants, it says aim for the patients to be 1 to 2 litres positive. So for your low-risk patients, don't be worried about giving them that litre around the time of induction of anaesthesia, and don't worry if you deliver them to the recovery area about plus 2 litres, because currently that appears to produce the best outcomes. Certainly don't deliver them at zero balance or dry. For most of them, you're into some form of guided therapy that goes with it. My last 2 top tips for this year, there's a lot of chatter going on out there about hydration. So we don't like to keep ourselves hydrated. Many of our patients ended up dehydrated. Now, what do I mean by that? Many of them end up salt and water overloaded, i.e. 1 to 2 litres positive post-operatively, which seems to be the right thing to do. But as we know, those litres of fluid that we give them contain a huge amount of salt. So they're often in this crazy situation where they're salt and water overloaded, but they're thirsty, because what they're sensing is the high salt levels. We've just given them 50 extra bags of salt or potato chips. You've all seen those slides. So they're sitting there saying, hang on a second, you keep giving me salt and water. I want water, let me drink, let me drink. And if they can't drink, what we've been testing, here's one of our publications, is we've been, like patient-controlled analgesia, we've been letting them do patient-controlled hydration. So we've given them a bag of D5 half and a button, and they can hit the button until they don't feel thirsty anymore. And in healthy volunteers, don't let a man have a control when he's tired at night. In healthy volunteers, if you do give them the button so they can give themselves their own hydration, it works extremely well. They nail it, basically. Let them say, I know best. I know when I'm thirsty. I know when I've had enough. Give them the button. Let them push the button. It's been working. Will it work in patients? There's a number of years' work to do on that, but that's ongoing at the moment. My final exciting announcement, I'm sure you all know about this already, is the computers are coming. We've repeatedly demonstrated that I know someone in the room is really, really good at perioperative fluid management and hemodynamic management, but sadly most of us aren't. So when we look at the observational data, it's all a bit chaotic. So maybe we need a little bit of help from the computers. This is developing very, very rapidly. So the use of artificial intelligence and closed loops to keep the blood pressure infusions, the drugs infused at the right level, to keep the fluids going at the right levels is happening rapidly. We see approved for the first time this year, it was announced at the American Society of Anesthesiology in San Francisco last year, a product from Edwards Life Sciences, the first FDA approved, as far as I know, in our space, use of artificial intelligence to help us make better decisions. There was an article in the Wall Street Journal in May of last year entitled "The AI, the Artificial Intelligence Doctor, Will See You Soon." And within that, one of the examples they gave is this, which is the Acumen Hypotension Prediction Index. On this screen, when you get a chance to look at it, there's a new number in the top right-hand corner that looks a bit like an arterial oxygen saturation. It's a number in red there that says 96. The difference here is the machine has used artificial intelligence to determine the likelihood the patient is going to have a hypotensive episode. So it's a bit like the app on your phone that tells you there's a 70% chance it's going to rain at 4 o'clock tomorrow. This says there's a 96% chance that this patient in front of you, who is not hypotensive at the moment, is going to become hypotensive soon. I've seen it in practice. I've used it quite a lot now in various different laboratory settings. What's really cool about it is you don't have to treat it. What you do is you trigger and you say, I wonder if they are going to become hypotensive. So you have a look around and you say, gosh, there's a bit more blood in the bucket than I'd anticipated. I wonder what they're pulling on. And you react and do the things you would usually do. Your attention is drawn to the fact it's about to happen. So I look forward to discussing that in the Q&A. Those are my top tips and update for now. I think now what we're going to do is get into the discussion period and welcome back Desiree Chappell. Desiree, welcome back.
We are going to drop the mic because I think that we're going to be able to get through without it. Most of you guys can hear us. So we're going to go ahead for you guys here and for everyone at home, pull up Slido. If you guys don't care, slido.com. We will obviously take questions from the audience. Again, if you guys have questions, please make sure you have the mic before you ask the questions so everyone at home or wherever they are can hear. I am going to go ahead and load some of these questions here. I know one of the questions we had earlier was, can Monty get his cold beer? Are you okay? It's over there. We'll get it in a minute. Okay, hi, Mom. So please, if you're at home or here, go ahead and vote up some of those questions if you like what's here. If not, go ahead and ask some other ones. It looks like all of them are about the same. So tell us more about TopMedTalk. You want to do that? Let's talk about TopMedTalk.
Well, for those of you in the room, we displayed TopMedTalk a little bit earlier. Those listening at home, you know a little bit about TopMedTalk already. It's a free, open source media to share education as cost effectively as possible, democratizing education. We've been doing that for the last year using mainly podcasts. So last year we put out a podcast every day. We're on track for about 150,000 downloads in 130 countries. In the USA, until relatively recently, the only place that we didn't have a listener every single day was a place called South Dakota. Now, does anyone know what goes on in South Dakota, of which people were telling me not very much? Our listeners in South Dakota, thank you very much indeed, because now the whole of the map of the USA, we have listeners every day of the week. Completely free, open source, a podcast per day. The thing we're experimenting with this year is carbon-friendly conferencing. These events that we're going to do, pop-up events, in venues like this, and at the same time we're going to be connecting with multiple similar events that are down the road from other people around the country and around the world. So we create a large virtual meeting that will go to hundreds and then thousands, such that we can share local knowledge and international knowledge with a short trip down the road. Good for the planet, good for everyone. Yeah. You can still go on your long trips to Hawaii or whatever it is.
If you have CME money to burn, it's great. But
that's the big challenge. Yeah. And thank you for being our guinea pigs for experimenting with this tonight.
Luckily, I know a lot of you guys in the room, so you can give me your feedback later. We'll talk about it. All right, let's get into the meat of this. So the first question, this is a good one, because I know that at Norton's downtown, you guys are starting a lot of spine cases and starting enhanced recovery for spine cases. So the first question for you, Monty, is for prone patients, do you recommend using stroke volume or stroke volume variation?
For me, stroke volume.
Yeah.
I think there's too much going on, and there's some literature that helps you try and understand what to do with stroke volume variation. But for me, there's too many uncontrollable variables that may mess with it. So I think keep it simple. When you change position, you can understand how stroke volume responds. Mm-hmm. If it goes up by doing a sensible intervention, which is within the bounds of not fluid overloading a patient, for example, you can be really confident you're doing the right thing. I still don't completely understand how to interact with stroke volume variation in a prone patient, so I'm a no for that. What about you, Desiree? Would you?
Well, whenever we first started enhanced recovery at Audubon Hospital, where I used to work, we actually had two different protocols, and we used both of them. And what we found was that there are several limitations to stroke volume variation, and I think that you kind of, once you get into it, you kind of forget that there are those limitations, especially if you have a patient that is high risk and you're really monitoring them closely and you're trying to work on other things. So what we decided to do at that time was just to use stroke volume. And I know there are a lot of facilities around the country that are just choosing one, and stroke volume is usually the one that people end up on. So stroke volume is usually a better way, and I think that it works better whenever you're using a protocolized situation. So that's my opinion. I'm going to add a couple more questions in here. And please vote these up and down if you like the question. We're just going to keep going down the list because it looks like two people have looked at this one. So please speak to the cost-benefit considerations that may be yielded from enhanced recovery. And we're not talking about necessarily fluid therapy, but just enhanced recovery in general. So give your background a little bit to this, I think, first.
Well, sorry to keep harping back to it. I was privileged to lead the national spread and adoption of enhanced recovery principles in the National Health Service in England, starting in 2009 and finishing in 2013. We started off in the four major typical areas of colorectal, orthopedic, major gynae, major urology, and our conclusion was Not only was it better for patients, it turned out to be better for patients in the short term, and now we're seeing the results that it's better for patients in the long term. So we're getting strong signals that cancer survival rates are better. It always seems to be very cost effective. So we saved hundreds of thousands of bed days and tens of millions of UK pounds, and that has persisted to be the signal from it. And it's now spread to all forms of surgery. I haven't seen anyone launch a program anywhere who's reported that if they've done it properly, that they haven't had that return.
And I would say the same. And you know, a lot of people are concerned, a lot of surgeons are concerned, I don't want to kick my patients out earlier. I know you're trying to save money on length of stay, but it's never that. You're never kicking anyone out. You're sending them home when they feel like they're ready to go home.
For most systems, the reason you want the bed back is to keep productivity going, to keep the bed usage. If the patient really wants to stay, they're not going to be burning a whole load of dollars compared to being there because they've got more morbidity. The thing that costs a lot of money is if they're getting CT scans, MRIs, antibiotics, additional treatments, intensive care. Yeah. The hotel costs, their insurer maybe then, they may end up burdened with a cost they didn't need, but actually it's a much smaller number compared to, you know, I had a stroke, I had an MI, I had avoidable complications, I developed acute kidney injury. So.
Yeah, that's where that comes from. If you guys have a question in the audience, please raise your hand. We'll get the mic to you. Okay, so.
But do speak into the mic or it won't be captured forever.
This is a good question. And the next question here, what does enhanced recovery for obstetrics look like? And we've focused a lot on that with the evidence-based perioperative medicine group. Our last conference, we had a whole session dedicated to that, and in March we will as well. Monty, what have you guys done in the UK with obstetrics?
So interesting, 2 stages of that. A lot of obstetric practice looks a bit like enhanced recovery anyway. So particularly, you're in a slightly unusual situation here where, as far as I understand it, by some sort of quirk of law, there's a right to stay in hospital for 4 days after a cesarean section, for example, if you want to. We never got round to that in Europe, for example. And many of our mums, the majority actually, want to go home as quickly as possible. Now, I know all mums in the room will know there's a variation of opinion on how quickly you want to get home to the rest of the kids, including the biggest kid, okay, after new kids have been born. But the most important thing is they want to get going as quickly as possible. They want to be able to look after their new baby as quickly as possible, and they want to be free of the drips and the drains and everything else that looks like it. So traditional obstetrics has looked at quite like enhanced recovery. Now, modern C-section enhanced recovery looks exactly like enhanced recovery. Day case cesarean sections are completely possible. 24-hour stay is common in very many places, including very many places in the United States of America now. Certainly 48 hours is pushing the envelope. Why you need the day 3 and day 4 is hard to fathom.
Yeah, I think there are a lot of facilities, East Coast, West Coast, that are adopting enhanced recovery principles. And they actually look a lot like what we're using for enhanced recovery for open abdominal cases. I mean, it's very similar.
A lot of recorded convos on TopMedTalk about that subject area.
So. Yeah, pain management, fluid management, all those things look very similar.
It's a big ticket item for our countries and our health systems. Yeah. The biggest bed users in our healthcare systems are cesarean sections.
So in here right now with everyone, we have our group here from Norton Women and Children's, and downtown actually do the majority of obstetric cases here in Louisville. So, and you guys are hoping to start doing some enhanced recovery for that? Yeah. Can we get to the mic? Have you guys, I'm putting Rob Schweers on the spot because he's my friend, and I can. I can love Rob Schweers. No, so, I mean, honestly, for obstetrics and using enhanced recovery, you guys have been using enhanced recovery down in the main OR, but how is it translating to your patients?
And Desiree's deliberately chosen one of our speakers who's behind the pillar, the only one who's behind a pillar for the camera.
Oh, that's right, you can't see him, but he's okay. There you go.
I did that purposefully. As we've seen, there's a lot of politics involved with getting the order sets and the direction from the actual hospital. So it's slow moving, but we're hoping in the next 6 months we will have designated ERAS for obstetrics.
Excellent.
Yeah, that's awesome. And you guys have a lot of experience down in the main OR with those abdominal patients.
Correct.
You don't have to answer. That's good. No, I think it's good.
It's called leading the witness.
Yeah, I know. It's fine. I'm not a lawyer, so it's totally fine. I'm going to get Audubon in here in just one second. No. Okay, next question. Have enhanced recovery protocols led to decreasing rates of post-op delirium or post-operative cognitive decline? We talk a lot about this on Top Med Talk, actually.
There are strong hints of it in the literature. Professor Henrik Kellett would say absolutely, and this has been in discussion a lot with the Brain Health Initiative, recorded on Top Med Talk with people like Lee Fleischer. Professor Henrik Kellett says a lot of the secrets to avoiding post-operative cognitive dysfunction, delirium, is just basic enhanced recovery principles. Because you're going to get people off their opiates quickly, you're going to get them mobilized quickly, most importantly, you're going to get them home quickly, which is, I think we all know for our elderly folks, is the most important way to avoid them getting confused in hospital. It should be the secret sauce.
Yeah.
Has that been proven yet? I don't think so. I think it's great ambition. My hunch is it will play out to be true, but I don't think we know that yet.
No, and what I think is great though is that when we talk about enhanced recovery and post-op cognitive dysfunction and delirium, is that it's coming to light of things that we have normally used on an everyday basis that actually can cause post-op delirium. And it has really brought to light, like in my mind, thinking about what I use every day when I'm not seeing the patient on post-op day 2 or day 3 can actually be affecting them. So we're gonna take a question from the audience. Dr. Josh Campbell.
I do have a question about the post-op delirium. Are you all reducing some of those things, reducing the amount of Versed that you're giving, or giving Risperdal and pre-op, or, risk stratifying your patients, giving some Haldol, or, are there medicines that you're using, medicines that you're not using in addition to the ERAS principles? Because even if you do all of those things, we're still seeing it happen.
Yeah, I think we're all still seeing it happen.
Yeah.
But it's not an area of expertise of mine, but I've asked that question to a lot of experts now. And they say, number one, the most important thing is to screen for it so you recognize it. Number two is to work with family and friends to see how you're going to get them to the place they want to be as quickly as possible. What makes mum or pop happy? What makes them unhappy? That sort of thing. And then the main thing after that is, apart from good hemodynamic management, enhanced recovery principles, think about constipation, think about bladder obstruction, think about pain, and then don't use any of the drugs that the geriatricians hate. And midazolam, Versed, is top of the list.
Yeah.
If you look at some of the animal experiments about how long a previously healthy rat who's been given some Versed is doulally for, if they're susceptible after a single dose of Versed, you'd never give it again under those circumstances. So I think listen to your geriatric colleagues. Whatever they wouldn't give, whether it's ranitidine or Versed or some of the antiemetics, just get the list and don't give it, because we don't need to.
No, I think that's the biggest thing too. I mean, I know that Versed in the Audubon Enhanced Recovery Protocol was one of the first things that we got rid of. I mean, you're still going to see incidences of that, but again, like talking to geriatricians and some of these other people and using that multidisciplinary team approach to care, like what we should be doing in enhanced recovery, I think some of those conversations, we should start having more of those to develop our protocols. So. How far behind in the U.S. versus Europe are we in enhanced recovery? Don't answer that question. I know, I've been to many of the conferences over in the UK and Europe, and there is a difference.
Yeah, I don't think Europe's as complete ERAS as you get the impression it is.
Yeah,
And even our most recent, although we had this whole national campaign in the UK, after we took our foot off the gas, it slipped back again, such that when we did our most recent deep dive into how many people are really complying with all the pathway elements of enhanced recovery, it's more like 60 to 70% of all surgical pathways have pretty complete compliance. So it's not as though the whole nation has 90+% of patients drinking, eating and mobilizing after all forms of surgery, which is our national goal. But it's not gone back to the sort of 5 to 10% it was before. So we're going after that again. Other countries in Europe are pretty complete. I get the impression in the US, your ambition is greater than Europe and the UK, but you're still pretty much in many places getting going.
I think from my perspective as someone in the US that hears what they're doing in the UK, you have a lot of, or several initiatives and several studies that have looked at compliance and looked at like what you're actually doing for quality improvement and looking at enhanced recovery. I think for us here in the US, a lot of people want to get going and get started, but and it's great whenever we get started, but we're not really monitoring what the compliance is of enhanced recovery and like what people are actually doing. So you write a protocol and it looks fantastic, and you may be doing it interoperatively, but what are all your other colleagues doing throughout the entire perioperative continuum?
Yeah,
So that's kind of what I feel like is happening in the US. Like there's some gung-ho people. There might be a pre-op person that's in PAT and really gung-ho about some of that, but the anesthesia team is not involved or post-operatively. So I think some of those things that we don't look at the continuum of care is different than
I think
in the UK.
places have done it best is where their systems allow them to track compliance.
Yeah.
Compliance is consistently above 80%.
Yeah.
Because if you let natural prejudice creep back in, it drops down to about 60%, and then you might as well not have bothered. So the places that have 90% compliance, 90% drink, eat, mobilize rates are fantastic. One thing I would say is, you've got pretty nationwide adoption of electronic health records. They need to become the solution, not the problem.
Yeah.
So as far as I visit so many places that tell me that, I'm not going to mention names, but this EHR or that EHR and the others are the problem, not the solution. They need to become the solution.
Yeah.
Now, they have in some places, but universally they should be the solution.
Yeah, I agree. Well, that's going to wrap up our first session. We're going to take a quick break, and for everyone at home, thank you so much for listening, but we're going to take a quick break to reload on drinks, take a bio break. We'll come back in about 10 minutes, so we'll see you back then soon. So, thanks.
Thanks very much.
Yes. We're
we
going
do the
live.
same sequence again?
Oh, yeah.
Okay.
We're going live.
We're not streams off at the moment, is it? Okay. We'll get it right next time.
All right, so welcome back to TopMedTalks here at 8020 Kalen's in Louisville, Kentucky. For everyone listening at home, thank you for joining us and thank you for
Desiree, your audio's down for some
going
reason.
with us. Okay. Are we on? You got me? Okay, great. All right, this is the beauty of live. We're going to call it TV. It's not really TV, but that's okay. Again, thank you all so much for joining us. We are back here. The rest of the time that we're going to spend here is going to be a Q&A through Slido. So if you're listening at home, please join us on slido.com. You can put in questions. Please put where you're from because we'd love to hear where everybody's from. If not, that's okay. Everyone in the audience, if you do have a question that you want to talk and have a conversation with us, just grab the mic before you start talking to us. Cool? All right, great. So I'm going to ask Professor Monty Mythen to come and join us back again. So Monty, woo! All right. So we're going to go ahead and start with questions. Are you good with that?
Yeah, great.
Good. Anybody have a question right now? No? Okay. We'll go ahead and start with Slido. We've had a couple great questions during the break. Hopefully we can come back to those. But some of the questions have been voted up here. So our first one, what are ideal case time frames for using enhanced recovery principles? What about MAC anesthesia cases? So Monty, is there a time, like enhanced recovery depends on the time of the case or what?
Let's flip that over. I think, again, to refer back to Henrik Kellitz, the father of enhanced recovery, he basically says that all surgery should be performed as a day case, so like MAC anesthesia. So the aim is for everyone to go home today. That's the objective. Now we know many of those patients can't go home today, if you've had an esophagectomy, for example, but the principle should be the same. You should be turning around and saying, it would be great if you could have the patient in such a condition that their bag is packed, ready to go home today, and if not today, tomorrow. Now we know some of those people are going to be in hospital for 5 days maybe, but the idea that they have to be in hospital for 2 or 3 weeks is long, long gone. So for MAC anesthesia, you'd hope, if it is truly MAC anesthesia, it's basically enhanced recovery, if you see what I mean. It's kind of like you've come in, you're going to have a little bit of whatever it is, and you're going home. Yeah. Other principles about like starvation, nutrition, managing expectations, what to do when you get home, those all apply.
Yeah, it doesn't depend on if the case lasts 30 minutes or
But, for MAC anesthesia cases, very simple things. It's a bit like, do they fully understand what's happening?
Yeah.
Have you made sure that they're not going to be hungry and thirsty when they turn up? Crazy levels of NPO, so somebody turns up for their MAC case, starving, dehydrated, hungry, that all needs to go.
It's funny because the same day cases, even though like the institution may be utilizing enhanced recovery and their gastrectomy or colon patient, their NPO time has been changed to 2 hours, their like skin lesion that they're having removed, their NPO time's still, after midnight or whatever. So I think it's something to think about, and I think when you're first starting out, it may not be at the front of your mind or front of like the PAT, what they're doing, but it's definitely something to think about. So. Oh, Chuck Norris is in the audience this evening. I don't know. I don't know if he's here. I don't know if he's at home. If you are, thanks, Chuck, for joining us. I didn't realize you're so.
Hey, Chuck.
Yeah, so involved with enhanced recovery. But let's talk to Chuck here. All right, Chuck. Your question is: please share your thoughts on opiate-free anesthesia. Will there be a future for opiate-free anesthesia in the pre, intra, post-op setting to go with existing enhanced recovery principles?
Now, Chuck, I know why this question is important to you in particular, so we've got that one. I think that there's a big push for opiate-free anesthesia. On balance, this is another one of those pokey guideline groupings. We had it in Vanderbilt towards the beginning of last year. The papers are in press at the moment about our relative contribution to the opioid crisis and what we can do to try and reduce our contribution to the opioid crisis. And one of the big debates there was whether we should try and go opiate or opioid free. And there is a sort of group of let's call them zealots, I think it's a bit harsh, who think that we should try and go completely opiate free. I think there's very many more of us who turn around and we should try and go opiate light, i.e. it's a big paradigm shift. If you've always given 100 of fentanyl around the time of induction of anesthesia, that may or may not be important. It may or may not contribute to opiate craving later on. But right at the moment, let's take on the big issues step at a time. And the big issue is probably avoidance of very addictive opiates, only using opiates when everything else doesn't work. So, multimodal analgesia, opiates are the last resort as opposed to first resort, and stop sending people home with sacks full of addictive drugs. So to get a grip on those things. So most big cases you can do, very many big cases you can do with very little opiate. Opiate free, you can do it, but I think that's phase 2 for me.
Yeah. I mean, there's been a lot of conversation about opioid free, and some of the concerns that I have heard is that even though we can make it through surgery without opioids, it doesn't mean that, well, first of all, we don't actually know what that means post-operatively, what they're experiencing on post-op day 1 and 2. So we make it through, they wake up and pack you, they're not in pain, that's fine. Do we not give them opioids the rest of the time, and what does that look like? And then if they need a ton of opioids to get them through because they're in so much pain because we didn't give any opioids and we really didn't cover them any other way, what does that look like for the patient then afterwards? So I think those are a couple questions that we have to look at. I think opioid light, opioid sparing is kind of where we should start out. And looking at the whole continuum, even though there's anesthesia in the room, we only really focus on intraop, but thinking about what that means throughout the entire continuum of care and if they receive a little bit of opiate or not. I think also is having the conversation with everyone involved, post-op nurses, what the surgeon's going to be sending home, because those are things that are often a second thought for a lot of people. So
there's a very challenging presentation done by Matt McAvoy, who's a physician, one of the leaders at Vanderbilt, that was recorded at the last Chicago meeting, EdPOM meeting, and we asked him to do a short talk about can we, the anesthesia providers, kick the habit. So it would appear that from the point of view of our contribution to the opioid crisis, of which the conclusion is we are not insignificant contributors to it, so 5 to 10% of people in the United States of America who are opioid naive, who go for major surgery, end up addicted. That's, just to reiterate that, 5 to 10% end up addicted, and the first opioid they got was from one of us. Now, maybe they would have gone that route anyway, but possibly not. So the real challenge is, if anyone's got to kick the habit first, can we kick the habit? I.e., our habit is to give opioid, here's a sack full of opioid to go home, don't phone me. Now, I know other people are involved in that, but the big challenge to us is let's tidy our act up first.
Yeah, and I think it's actually a pretty easy conversation with the surgeon as well, because we all know every day in practice, I do whatever I do intraoperatively, but the surgeon may be writing those scripts home. And if I've done everything I can to reduce the amount of opioids, we should be working with them to reduce the amount of opioids that they get afterwards too. So, next question, which I think is good, and switching kind of to fluid, is what guidance do you have for utilizing GDFT or goal-directed fluid therapy on patients that have had spinals and epidurals? It's a good question.
Great question. So I think if they got an A-line in, then you can use technologies to take the A-line signal and decide when you should step in with your vasoactive agents, because we know that's always the challenge.
Yeah.
We're inducing hypotension. We don't want to give vasoconstrictive agents to people who are relatively hypovolemic, but we don't want to fill the whole tank with nothing but fluid. So when is it the right point to step in? So you can use your A-line signals. Now, having an A-line in many of those cases was not what you were planning to do. So now there are technologies that are non-invasive, including finger squeezing devices, etc., whereby you can turn around and say, well, in this case here, who's a little bit more frail, I do want to know cardiac output stroke volume. I'm going to start with a little bit of fluid management, but my vasoactive agents, and particularly my vasopressors, are going to be available soon. I'm going to do that balance between, I'm going to, all right to be +1 up to +2 litres, but if I've gone +1 and it's not happening, I'm stepping in early with my vasoactive agent, increasingly as an infused agent as opposed to a bolus agent. So I think the principles are fundamentally the same. What you can't use reliably is stroke volume variation, pulse pressure variation, because they're usually spontaneously breathing. So it's stroke volume variables, cardiac index variables, but same principles, preload, afterload, contractility.
I think whenever we first started utilizing stroke volume variation to guide fluid therapy, we all know that we were using multimodal, and so utilizing spinals a lot in the practice that we were doing, that there was the question of like, well, I know I'm having a sympathectomy, so I know that they're vasodilated. So do I give them fluid? Because whenever that wears off, what if they end up, a couple liters positive, or, if I'm treating to that? So.
That's still one of the known unknowns, but the idea that they came in perfectly euvolemic and perfectly hydrated seems on balance to be unlikely. Being +1 to +2 litres is an area of safety. What you don't want to be is +3.
Yeah.
So the way to use for more complicated patients with multiple comorbidities to move up to your advanced hemodynamic monitoring is to rationalize the point at which you use a vasopressor.
Yeah. Agreed. That's a good question. All right, next question. TIVA enhanced recovery versus gas enhanced recovery. Any big differences seen in the length of stay or recovery in the results?
I think there are some strong, like big picture. If you want to do enhanced recovery, you can do it with either. Okay, so I would say it would be not a sensible move to try and make everyone switch to one or the other to try and deliver your enhanced recovery program. There's quite a recurring theme in many of the observational studies of large databases that outcomes look as though they may be even better using TIVA compared to gas. Mm-hmm. Now, I don't give many anesthetics, you could argue any anesthetics anymore, as a professor who mainly does intensive care. But I was always reluctant to switch to pure TIVA. I'm under increasing pressure, I would argue, to consider it, particularly with some of the cancer literature that's coming through about cancer recurrence rates. So I'd keep an eye on that. Do you need TIVA to do enhanced recovery? I think no is the answer. You can do it perfectly well with whatever anesthetic you're giving at the moment. From the anesthesia per se, you can make it work.
Yeah, so nothing's really come out to say one versus
No, but if you look at some of the big observational studies, the TIVA being associated with even better outcomes is a recurring theme. Yeah. So that may change.
And there are a lot of protocols now that are kind of switching over, especially with multimodal and using regional anesthesia and doing TIVA only kind of stuff. So we probably should.
But if you're going to do TIVA, you've got to do it well.
What does that mean?
Well, if you look at the large observational studies that we've done in the United Kingdom about awareness, for example, you're much more. It's rare, but you're much more likely to be aware if you have TIVA done by an amateur enthusiast. If you're into TIVA, you need to be into TIVA. Does that make sense? You don't want to do TIVA occasionally on a Thursday afternoon. If you're into TIVA, be into TIVA. Because there's a lot of things you can take your eye off the ball, you can connect, you need to be set up right. We're all set up to give the gas anesthetic.
Do you think there's one patient population that because I feel like TIVA in the places that I've been before, like we kind of have a specific patient population. Do you think it's that we can generalize it to everyone?
I think it's a big known unknown.
Yeah, it's true.
The TIVA enthusiast would make you believe that it's a secret.
Yeah.
But I wouldn't be surprised if we're talked around.
Agree. So a lot of things. Let's see. There's a lot of discussion about crystalloid versus colloid, but at what point is hemoglobin hematocrit considered as part of enhanced recovery?
So I think your transfusion triggers, we have national transfusion triggers if you breach them. So our transfusion trigger is 7 grams per deciliter or 70 grams per litre of hemoglobin or a crit of 21. So if you transfuse with a patient when you verified that who is above that, then you're at risk of serious criticism. Now you can adapt that to individual patient needs. We all know how to do that. The big ticket item really with hemoglobin and hematocrit is making sure they don't come to the OR anemic. Mm-hmm. So I'm sure you've all got or are getting anemia clinics. The big signal for treating preoperative anemia, of which very many of our patients are, is it dramatically reduces transfusion requirements. You can almost eliminate it in very many cases. So that many cases have gone with their major joint programs to almost always transfusing a knee to never transfusing a knee, because they fixed the anemia beforehand with typically intravenous iron therapy. And again, we've got lots of recorded lectures about that. Do you have anemia clinics?
I was just going to say,
anemia?
let's ask the audience, who has an anemia clinic here? Nobody.
So that interview you had with
Lori Heller.
Laurie Heller.
And
so what was the
Bobby Jean Schweitzer.
What was the crit they have to have for all procedures before they go to the operating room?
32, right?
Yeah, you know, in other words,
Yeah.
they don't take anyone to the operating room.
They will not go to surgery unless they have a crit of 32. It's an absolute.
I.e., there's no patient going to the
Yeah.
operating room anemia.
That's not enhanced recovery. That's any other patients.
And avoidance of transfusion is the big
Yeah.
recurring theme. So I know more about Duke, for example. Duke has an anemia clinic. It's pretty standard now. It's increasingly standard practice in the UK. Why would you go anemic? Why would you choose the blood
Yeah.
transfusion as opposed to fixing something? She even cites cases whereby the thing that they thought was making them sick, when they fixed the anemia, they didn't go for the surgery.
They didn't go for the surgery.
Because they said, oh, well, it's not my gallbladder, it's my anemia.
Yeah, that to me was one of the most enlightening conversations that we've had. Is that the one, if we fix the anemia, we don't actually have to have surgery at all, and two, that you're actually canceling cases that would never, that would typically go back, that will not ever reach that threshold. So
the other conversations we've been having is the increasing recognition of, let's call it normal social anemia.
yeah,
So in other words, when I'm old, so when I was a youngster, my parents were post-war parents. There's a lot of malnourished people around. So we were routinely screened for anemia, and we were given food supplements and milk supplements in London to treat our common anemia. Mm-hmm. That's sort of gone away. And now when they've done screening programs at University College London, for example, of students, a large proportion of students who think they're otherwise healthy are anemic. Mm-hmm. And the most anemic students are females who do high impact sports like run long distances or do kickboxing, etc. And they're often profoundly anemic, and it is associated with depression, fatigue, etc. Mm-hmm. So there's some really interesting, it's really common, because you go to university, you're an athlete, you run long distances, you've got less money, you become a vegan because that's what you decide to do. You can't buy a lot of high quality vegetables. You go to the local store, you buy the vegetables that are available, your anemia is getting worse and worse.
yeah. It's been the anemia question has been huge. And I feel like it's difficult for us as anesthesia providers that may see the patient literally for the first time before they have their surgery, but it's definitely something that we need to start thinking of and adapting in our enhanced recovery for sure, if not for all of our surgical patients. But
The last big question.
it is kind of a big question to end on here. When will new Edwards technology be out for use? And I don't know what you mean by the technology, but I'm assuming the HPI that Monty referred to.
So the HPI, which I encourage you all to have a look at, it's not, as far as I understand, it's not on, it's approved by the FDA and it's available to a select group of people at the moment. It's a big paradigm shift.
Yeah.
So I think Edwards, as far as I understand, are being very responsible in a controlled release. Because it's one of those things where it's such a big paradigm shift, we're all at risk of getting overexcited about how to use it. So it was launched in Europe. Our regulators have a slightly different approach over a year ago. And there's a lot of European experience that's now been published about it. The FDA approved it. Now to get FDA approval, that means it's been through the ringer. So it's been right through the ringer to say, we believe that we understand what this number has to offer, and we believe it's ready for mainstream. So as of, as I said, the ASA, October last year, and correct me if I'm wrong, guys, if you know more about this, it's sort of soft launched in the USA. So it's announced to say that this technology is available and coming your way soon.
Yeah.
Now, a certain number of programs, as I understand, have been given the technology to evaluate it. So it's a sort of combination of trials, clinical trials, and a combination of concentrate really hard and use this new device and this new number to tell me how you think it's working in your practice. Now, I think this year you're going to see a much bigger launch. I think we're really going to be exposed to what does this sort of thing have to offer? And coming in hard behind that are the closed loop therapies. So assisted fluid management, I don't know if any of you have taken part in the trials. There's been for a number of years now the idea that you take your fluid infusion device, you link it to your arterial waveform technology, and rather than us saying the stroke volume is going up and down, I may or may not give a fluid bolus, you let one device talk to the other, and it's just like autopilot, you let it happen on its own, with a little bit of physician input. Now that's been happening for a number of years now in laboratories and in humans, and is now in clinical trials in the USA. So soon, you may have a situation where either the device says, by the way, it looks like you should give a fluid bolus, do you agree, provider? And you go, oh yeah, sure, I've had a look at it, great. Or beyond that, it will just give the fluid boluses to keep everything on track, and coming in hard behind that is your vasoactive agents will be given things on track as well. Now initially we're thinking, oh, that's crazy, that will all go horribly wrong. The disturbing thing is, like many things that happen in life, it would appear as though the machines are better at this than we are. It's a bit like the self-driving car analogy. We all think, no, the self-driving cars are going to bump into each other. We bump.
Is that a good analogy?
I know one has. Well, all right, one, as a result probably of human error from an extraneous, has been involved in a car crash.
True.
We have car crashes we nearly had about 5 this week, not when you were
with
driving.
me driving.
You know, so we've seen plenty this week.
That's true.
You know, so it's highly likely, not to take our jobs away, but it's highly likely that computers are coming to help in the same way as we've let them help lots of other places already.
Yeah, your iPhone does everything for you now. It's good.
So it's an exciting year. Keep on it. There's going to be lots of other AI, machine learning stuff. It's happening really rapidly. In X-ray diagnosis, for example, we'll be there very soon. You know, the computers are much better at looking at the patterns on the X-rays than humans are, particularly at 3 o'clock in the morning. And they have a look at it and they make the diagnosis. That's all written up and it's happening rapidly. So, on that happy note.
Yeah. No. Any other questions from the group?
Any burgeoning questions about how do I get out of here and how do I get home as quickly as possible?
I know. We're close. One question I didn't see on here, and I was going to wrap it up, but I think that it's very appropriate because I know that the Norton system is that enhanced recovery is in many of the facilities here, and it's been around for a little while, but I know that a lot of facilities are looking to extend into other service lines. And I think that we kind of get comfortable with whenever we first start, and you're like, does this service line really need enhanced recovery? Do they really need monitors? Do they really need that? So, you know, some of the less complicated spine cases or some of the mastectomy patients and breast patients, like, what is your experience in expanding enhanced recovery to really all of our patients?
Enhanced recovery for everything. All forms of surgery, emergency surgery, fractured neck of femur, emergency laparotomy. Then you move it into medical pathways. If you were admitted with a pneumonia, or your mum or your pop was, or your whoever, why wouldn't you want to be drinking, eating, mobilizing, dressed and home as quickly as possible? The principles are fundamentally sound, and some of the large healthcare systems in the USA have a stated ambition to be total enhanced recovery systems, i.e., why wouldn't you do that for everyone? It has a huge, if you get people dressed we've all experienced this, even if we've had a bad flu or something like that. The moment you get redressed in your clothes, even if it's a pair of stretchy pants and a t-shirt as opposed to the normal prisoner's kit that we give people, and you get out of the bed and into a normal chair, you're recovering. So, you know, let's do that for everyone. And then let's address anemia, diabetes, fitness, mobility, smoking cessation, snoring. Let's address all of those issues and just total enhanced recovery. And we're going to get that done not next week, not next year. We're going to get that done in the next few decades.
Hopefully it's sooner than that.
We'll crack on with it soon.
Yeah, we're going good. Well, guys, thank you so much for everyone here in Louisville and everyone at home. Thank you so much for our very first exploration into video live streaming with TopMedTalk. We want to thank, again, Edwards Life Sciences for helping us with this and sponsoring this event tonight.
And our fantastic crew.
Yeah, and our crew from Little Giant Media. Thank you guys so much. We look forward to more conversations. Please join us.
And our venue, where are we again? Because I was driven here and it's sort of,
80, I know, we're at 8020 Caitlin's. And they've been so gracious to help us with this space up here, so that's great. And it's just that laid back, conversational thing that I think we're all going for, and that's worked really well. So again, thank you guys for everything. So am I missing anything?
Give yourself a round of applause.
Yeah, that's good.